Welcome. In this session, we will address a central topic in contemporary medical practice: regulation and quality in health services. I want to start with a fundamental idea. Quality in medical care does not depend solely on the physician having good intentions or a vocation. It depends on the existence of norms, standards, and ethical principles that structure the entire health system. Quality, in this sense, is a collective, institutional, and professional commitment. This topic is part of the Administration of Private Practices and Hospitals chapter of our book. However, what we are going to discuss transcends the merely administrative. We will talk about how national and international norms, evaluation models, official Mexican standards, NOMS, and certification processes all integrate to ensure that the care we provide is not only technically correct, but also safe, effective, and patient-centered. And here, I pose a rhetorical question that will accompany us throughout this topic. Can good medical practice exist without standards or external evaluation? Probably not, and that is exactly what we will explore together. Let's talk now about a pillar that supports the entire health system, although it often goes unnoticed: sanitary regulation. When we speak of regulation, we refer to the set of laws, regulations, standards, and norms. These establish the rights of patients, the obligations of professionals, and the indispensable minimums to guarantee safe care. The General Health Law, LGS, for example, in its first articles, Article 1 and Article 3, it reminds us that health protection is not only a human right, but also a responsibility of the state and of those of us who practice professionally in this field. But that regulation is not limited to a single rule. There is a normative hierarchy, from the Constitution, passing through laws like the General Health Law, regulations, and official Mexican standards, NOMS, all the way down to clinical guidelines, certification standards, and even jurisprudence. And something very important: regulation is not made to punish, it is made to prevent. It exists so we know what is expected of us, what processes to follow, and how to act with legal certainty. A clear example is NOM 004, which regulates the clinical record. That standard not only protects the patient, it also legally backs the professional and facilitates the continuity of care. The bottom line: regulation is not an obstacle. It is the foundation upon which safe, ethical, and professional medicine is built. Now that we understand the role of regulation, let's talk about something equally crucial: quality models in health services. When we speak of quality in this context, we are not referring to luxury facilities or cutting-edge technology. We refer to something deeper: that health services be safe, effective, equitable, and person-centered. In Mexico, we have a dual strategy. On one hand, there are the official Mexican standards, NOMS, which are mandatory. On the other, there are voluntary external evaluation processes, such as the hospital certification by the General Health Council, Consejo de Salubridad General. Internationally, we find reference frameworks like that of the Joint Commission International (JCI). These frameworks have inspired many of the strategies we use today. These models have something in common: they are designed so we can measure what we do, identify failures, and improve continuously. They evaluate everything from clinical processes to institutional management, patient participation, and organizational culture. And here is an important idea: a certified hospital is not a perfect hospital, but it is a hospital with a clear commitment to continuous improvement and to learning from its mistakes. Therefore, understanding these models is key for any health professional aspiring to practice responsibly and in a modern way. Let's now review how quality is organized within the national regulatory framework. In Mexico, health quality standards are structured primarily through three components: the official Mexican standards, NOMS, hospital certification, and the guidelines issued by the Secretariat of Health. One of the clearest examples is NOM 004, which regulates the clinical record. This standard not only establishes what a record must contain, but transforms it into an essential instrument of quality, continuity, and legality in care. There is also NOM 016, which regulates the organization and operation of hospitals. It sets the minimum requirements to operate safely and effectively. In addition to these mandatory standards, we have the certification model of the General Health Council, Consejo de Salubridad General. This model groups standards into structured topics such as patient safety, quality management, patient rights, continuous improvement. This model allows hospitals to be evaluated objectively, based on criteria aligned with clinical and administrative best practices. And here it is fundamental to emphasize something: these standards are not suggestions or desirable recommendations. They are legal and ethical instruments that protect the patient and also the health personnel. For example, let's imagine an operating room set up without complying with NOM 016. If something goes wrong, the consequences are not only clinical, they can also be legal and reputational, both for the institution and for the professionals involved. Having reviewed the national standards, it is time to look outward. We must understand how quality models are constructed in the international arena. The most recognized is the Joint Commission International, JCI. This body promotes standards ranging from patient safety to institutional leadership. The famous International Patient Safety Goals, which we will examine in detail later, were born precisely from this model. Another key player is ISQA, the International Society for Quality in Healthcare. Unlike JCI, ISQA does not certify hospitals directly. Instead, it accredits the organizations that certify them. This means that if a Mexican certification entity is accredited by ISQA, it holds an international endorsement regarding technical rigor and reliability. And of course, we cannot leave out the Pan-American Health Organization, PAHO. PAHO drives public quality policies based on a vision of equitable access, universal health, and human rights. Now, these models do not replace national regulation. However, they allow us to compare ourselves with global standards, learn from them, and adapt them to our context to improve. So let's imagine two scenarios. One, where a hospital obtains JCI certification, and another, where the hospital submits to no external evaluation. In which of the two cases do you think there will be better conditions for safe, systematic, and reliable care? Precisely for this reason, adopting or adapting these models strengthens the institutional quality culture and improves the experience for both the patient and the healthcare team. We now arrive at one of the most operational and well-known components of international models, the International Patient Safety Goals, also known as IPSG, or MISP in Spanish. These goals were designed by the Joint Commission International to directly attack the most frequent and dangerous errors in clinical care, and they do so very clearly through 6 concrete actions. First, identify the patient correctly. It seems obvious, but identity errors are one of the most common causes of adverse events. Second, improve effective communication among professionals. A poorly transmitted order or an undocumented call can have grave consequences. Third, improve the safety of high-alert medications. Due to their potency or toxicity, these require double verification to ensure correct administration. Fourth, ensure safe surgery. This means verifying the correct site, correct procedure, and correct patient. This implies very rigorous preoperative protocols, like the timeout. Fifth, reduce the risk of healthcare-associated infections. This requires both clinical protocols and effective hand hygiene measures. And sixth, reduce the risk of patient harm resulting from falls, especially in hospitalized patients with increased risk factors. These goals are not just for large or accredited hospitals. They are applicable in any clinical setting, and their implementation must be transversal, from nursing staff to medical specialists. The important takeaway: we must understand that these are not suggestions. They are essential practices to protect the patient and to allow every professional to act with confidence and responsibility. In Mexico, ideas about patient safety have not remained merely theoretical. Since 2013, the Secretariat of Health implemented a set of practices known as the Essential Actions for Patient Safety, or AESP. These actions are a local and mandatory adaptation of international goals, designed specifically for the context of our hospitals and health units. Among the most relevant are: 1. Patient identification, using at least 2 verifiable data points. 2. Effective communication, especially during shift handoffs or critical orders. 3rd, medication safety, including verification, storage, and traceability processes. 4th, safe surgeries, using checklists and safety pauses, timeouts, before every intervention. 5th, infection prevention, from hand washing to the rational use of antibiotics. 6th, fall prevention, through risk assessment and environmental adaptation. 7. Registration and analysis of adverse events, as a basis for learning from errors. 8th, strengthening the culture of quality and patient safety. These actions are not optional recommendations. They are part of the national quality policy and are evaluated during accreditation processes or sanitary supervision. And it is worth asking ourselves this rhetorical question: if we know that the majority of serious errors in hospitals are due to failures in identification or communication, why doesn't every service apply these actions with rigor? Implementing the AESP is ultimately a concrete way to protect the life and dignity of our patients, and also to practice our profession with responsibility. Now then, how do we evaluate if a hospital truly complies with quality and safety standards? One of the most complete tools we have in Mexico is hospital certification, granted by the General Health Council, Consejo de Salubridad General, or CSG. This process is voluntary, but extremely valuable. It evaluates not only what happens in the operating room or in consultations, but also how the hospital is led, how resources are managed, how care is documented, and how continuous improvement is promoted. The CSG certification model is based on technical, structural, and organizational standards, organized by essential functions. And why is this important? Because a certified hospital holds more than just a certificate. It has evidence that it has undergone a rigorous process that strengthens its culture of quality, its capacity to respond to crises, and its commitment to the patient. And although certification is not mandatory, many hospitals seek it for the benefits it generates: access to certain insurance agreements, convenios, institutional positioning, and even a better work environment. I propose you imagine the following: 2 hospitals, one certified and another that has not gone through any external evaluation process. In which would you prefer to receive care or work? The answer is almost always the same, because certification is a tool that transforms not only processes but also institutional attitudes. Having reached this point, it is important to pause and look at the practical impact of everything we have discussed, because regulation and quality are not abstract concepts. They have real, direct, and verifiable benefits for all actors in the system. For patients, the benefits are the most evident: greater clinical safety, care based on evidence, dignified treatment and respect for their rights, such as informed consent and confidentiality. For health professionals, there are also very clear advantages: greater legal certainty, clarity regarding functions and procedures, reduction of medico-legal risk when working within the regulatory framework. Furthermore, it facilitates clinical decision-making in complex environments. And for health institutions, quality and regulation imply improvement in operational efficiency, transparency in management and accountability, greater prestige before users, authorities, and insurers. In the book, we emphasize something I consider key: regulated quality is not bureaucracy. It is a structured way to protect the life, integrity, and rights of people. So let's think for a moment. If a hospital complies with standards not just out of obligation, but because it believes in their impact, how does the work environment transform? And how does the patient experience change? The conclusion: when quality and regulation are lived as a culture, not as a requirement, then we are truly talking about a transformation in health. We have reached the end of this topic, and I want us to keep one key idea in mind. Regulation and quality are not external burdens imposed upon medicine. They are an essential part of modern, safe, and responsible medical practice. Regulation gives us structure. It defines responsibilities and protects rights. Quality gives us direction. It drives us to improve and allows us to practice with ethics and evidence. Good intentions are not enough if they are not accompanied by safe and verifiable processes. A hospital is not excellent just because it has goodwill, but because it possesses standards, evaluation, and institutional commitment. And this is not just an issue for hospitals. It applies equally to private practices, clinics, and outpatient care. At all levels, quality and regulation save lives, prevent errors, and strengthen trust in the system. The topic we reviewed today is also a foundation for what is coming. In the following sessions, we will talk about medical liability, informed consent, medico-legal conflicts, and patient safety. All of that is built upon this foundation. And so, I close with this reflection. What kind of professional do we want to be in a transforming health system? One who complies with the minimum, or one who drives change through legality, ethics, and quality?